I think the RIRS is better than PCNL for preservation of renal function because it uses the natural orifice through the ureter. I prepare a surgical case. You can see some technical trick. I think it is effective for evacuating remnant dust during the RIRS case. This patient is 44-year-old male patient with multiple renal and ureteral stones. 8 to 10 millimeter size renal stone was detected on the routine health checkup 8 months ago, and he didn't feel any stone-related discomfort, and he was lost to follow up. And finally, 1 month ago, he visited the emergency room after he felt a great severe degree of flank discomfort, and just painkillers were prescribed. So he finally visited a local clinic to undergo SWL, and he underwent 3 times. The stones were not fragmented at all after 3 times SWL, so finally visited my hospital to undergo the RIRS surgery. This stone is a radial opaque stone, so we can see the ureteral stone in the left upper ureter. There is a small stone in the left upper calyx. There are 2 more small stones in the bilateral kidney, and this is the main stone, 1 centimeter sized ureteral stone, and you can see the severe grade of hydroureteral nephrosis. The renal function of the right kidney is slightly decreased compared to the left kidney. If the stone size is larger than 1 centimeter, or creatinine or glomerular filtration rate is out of the normal range, then I think I should check the renal function preoperatively. Around postoperative 3 months, I check the renal function again, and I compare. Regardless of the presence of stone-related symptoms, patients with renal stone larger than 1 centimeter, about half of them showed deterioration of the renal function. So at first I put the guide wire hydrophilic and very soft. I put the ureteral scope directly over the into the ureter, and you can see the ureteral stone first. And after that, I use the ureteral catheter 5 French, and this is for the insertion of the superstiff guide wire into the renal pelvis. So now, before I put the ureteral access sheath into the ureter, the urine in the bladder should be removed, because if there are much amount of urine in the bladder, then the ureteral vascular junction can be compressed, so the ureteral injury may occur. Okay. So now I remove the ureteral Foley catheter, and safety guide wire should be inserted. So I use the dual lumen catheter for this purpose. And now the superstiff guide wire goes. So I fix the safety guide wire using this tube on the right side of the urethra. At first I measure the appropriate length of the ureteral accesses before I put it in. And now it goes in. Now I'm using the 11 French Navigator accesses. Yeah, I am the first person to use lithotripsy in my country. We sometimes realize the necessity of disposable things, especially for multiple stones, or possibility of renal scope damage, or microorganisms resistant to multiple antibiotics. The sterilization process is considered some time-consuming process, and we should consider cost of the process. So lithotripsy can be a good, viable option to solve this kind of problem. I connect the irrigation system into the irrigation port first, and I use the automated and manual irrigation system as well together. For the working channel, first I use the 3-way connector and then a port cell to fix the location of the laser fiber. So it is my technical trick to avoid the scope damage, but I don't have any stress about that with the LithoView. So during dusting, usually I use only the manual irrigation system because the operative visual field is much better than the continuous irrigation system, and the stones don't go far from the operative field. So I usually use the manual irrigation system. Now almost all stones become very small particles like dust. There are some small fragments, maybe the size would be 2 millimeters. And this is the upper posterior pole. And now I'll check the upper anterior pole. So there were no dust, a small amount of dust. So and then I remove some stones for stone analysis and stone culture. So I use the dual lumen catheter for evacuating dust, and the one channel is connected to continuous irrigation system and the other is connected to the suction. So now I put the dual lumen catheter through the ureter access to the renal pelvis, and because of the characteristic of dual lumen catheter, the tip of the dual lumen catheter is located to only the upper pole calyx. So the essential points are patient should be lie in the translumbal position, so head down. And at the start of the procedure, I move the stones from lower pole to upper poles, the single, as far as I can, into the single upper calyx. And the stones can gather in the upper calyx, and I do dusting technique. And if the stones are changed into the small particles to go out through the channel of the dual lumen catheter, then I started to evacuate the dust through the dual lumen catheter. And dual lumen catheter size is 10 French, so I usually use the 11-13 French ureteral access sheath of Boston Scientific. So I do alternatively irrigation and suction, more than 10 times. I do the back and forth movement of the dual lumen catheter to maximize the efficiency of evacuating dust. The procedure should be gentle movement. If the ureter and upper pole calyx is straight enough, you can effectively use this technique. So you can see almost all dust already removed through the dual lumen catheter there. During the retrieval of the access sheath and scope, I check whether there is any ureteral injury or not. You can use the same material, the same product, but we can use differently. So, and it depends on the many factors like the difference of nation, country, and then socioeconomic status. And we should consider all of the factors to maximize the surgical efficiency with the same materials or products.